Good morning again. This second lecture is devoted to medium-sized vessel vasculitis. And here my conflicts of interest. And we start with the Chapelin nomenclature. As you can see, the group of medium-sized vessel vasculitis is quite limited to polyarteritis nodosa and to Kawasaki disease. And in fact, it's quite simple to recognize such disease, because they are also very different, except the fact that histologically, polyarteritis nodosa is not so easy to differentiate from Kawasaki disease. In Kawasaki disease, there is more granuloma and inflammation than in polyarteritis nodosa. Kawasaki disease is a pediatric disease. On this slide, you see a lecture, after a lecture, presentation of Professor Kawasaki in the middle, and I am together with Cornelia Weyand and Professor Ozaki from Japan. This disease can affect also adults. It is a necrotizing vasculitis. The etiology remains unknown, and treatment is made mainly of immunoglobulins and more rarely with steroids. The epidemiology, it is an Asiatic disease, but we see some in all the countries in the world now. In Japan, they see approximately 9,000 new cases each year, with an incidence of 150 per 100,000 in children less than 4 years old. Half of them are less than 2 years old, very, very small children. It's a one-shot disease in most patients, but sometimes you have some recurrences, and it is not a familial disease, only 2%. The characteristics of this disease is the presence of coronary artery involvement. The coronary aneurysms occur very early in the course of the disease, 10 days approximately, and the evolution is usually favorable. But we know now that the healing of these aneurysms and the vessel injury can favor the occurrence of late atherosclerosis. And for this reason, patients should be followed very late after the occurrence of disease, because the real adult problems occurs usually at 30 years old or later. The clinical symptoms are very close to other symptoms observed in children, but some special symptoms are of major interest. They have fever, they have a bilateral conjunctival congestion, there is a cheilitis affecting lips and oral cavity, a polymorphous exanthema, which can be something like rubella. There's a reddening of palms and soles, then a desquamation, and it is not so many diseases with desquamation. Cardiovascular manifestations, I already talked about it. And there is also other systemic manifestations like gastrointestinal tract involvement, cough, rhinorrhea, joint pain, and swelling. It is illustrated here. The strawberry tongue, shown here, the cheilitis, and the redness, and the conjunctivitis, which is bilateral, as you can see. In adults here, it is one of my patients. He had a necrosis of the fingers, which is not so usual, but you can see also the desquamation, which is of course very common in children. And retrospectively, you can make the diagnosis of Kawasaki disease if you did not make the diagnosis very early in the course of the disease. What is of interest is that we looked at the etiology of Kawasaki disease for decades, and nobody was able to demonstrate a cause of this disease. Many germs have been investigated, viruses, bacterials, and so on. And recently, when the COVID pandemic happened, pediatricians have described what they called a pseudo-Kawasaki disease and what we call now PIMS, pediatric inflammatory multisystemic syndrome. It is a vasculitis. It is not very frequent. In France, for instance, we observe in 1.5 approximately 500 patients. But there is some differences between what has been described by Kawasaki and what has been observed during this disease. First of all, the age. It's around 10 years, between 4 and 11. The first symptoms are a poor general condition. After that, abdominal pain, which is very intense, and the children go to the emergency ward because of the abdominal pain. And after that, very abruptly, a cardiogenic shock happens, and these children have to go to intensive care units. Fortunately, the outcome is usually favorable, and immunoglobulins are effective in 80% of the patients, and the refractory patients are usually treated successfully with corticosteroids. Now we will move to the second one. The second one is polyarteritis nodosa. And it was the leader of all the vasculitis in the past. This disease has been described in the 19th century by Kussmaul and Mayer. And progressively, in the developed country, this disease became more rare for different reasons, and I will come back on these reasons later. In the 80s, the incidence in UK was of 0.7 per 100,000 inhabitants. The prevalence, 6.3. In France, it was a higher prevalence in 2002, but a very low incidence. The reason is very easy to understand. At that time, we had really a lot of new patients who were infected by hepatitis B virus. We were able to treat the patients, to cure the patients, and of course the prevalence is high. But the incidence is low, and now, because of vaccination, IgN, and so on, the incidence is very low, and we think that the disease in this classical form is close to disappear. But we see some. The histology, the fibrin necrosis of the media, it is a panarteritis. The thrombosis, which is a consequence of the injury of the endothelium, and you have a perivascular inflammation without granuloma. When we look at the clinical manifestation in systemic disease, it is a very aggressive disease. Weight loss, 66%, fever, neuropathy, joint involvement, myalgias, and skin disease. All these symptoms are around 50% of the patient, between 50% and 2/3 of the patients. The other symptoms are shown here. The kidney involvement is very special. It is a vascular nephropathy. It means that patients have obstruction of medium-sized vessels and the arcuate arteries, and they have ischemic process in the kidney. The consequence is the hypertension. A GI involvement is also present in 31%. This is not too much, but it is probably the most severe manifestation. And the patients who die quite often from this GI involvement. The classical symptoms are the skin disease with the vascular purpura, the nodules, and the livedo. The neuropathy is a mononeuritis multiplex. It is sensory motor, and it affects mainly the superficial peroneal, then in order of frequency, sural, then the cubital, radial, and median. The nerves, the cranial nerves, are quite rarely affected. And the kidney, renal infarct, vascular nephropathy, and never glomerulonephritis. Glomerulonephritis can be only observed in small side vessel vasculitis, never in medium side vessel vasculitis. And I will show you some examples. On one slide, you see the foot with a vascular purpura. You see it's a purpura, you can touch it and you can feel the purpura. And if you make a biopsy, you will find in the deep dermis the presence of the necrosis of the vessel. But the other side of the slide is very interesting because it is autopsy and it is a kidney. When you look very carefully, you will see the alternance of some ischemic parts and some vascular parts. In this vascular part, you see the glomerulus, which are quite normal, and the other one, it is like a dessert. And it is a consequence of the ischemic process. It can be shown on other investigations like angiograms. The angiogram is shown here. It is conventional arteriography, which is probably the best test to illustrate the presence of this polyarteritis nodosa. But it is not so easy to make this investigation now because we have MRI, we have CT scan, and the images are not so nice, but I will show you the conventional one. And when the aneurysms are quite big, it is possible to detect them with MRI or CT scan. When they are very, very small, it's a bit different. On these slides, you can see the multiple microaneurysms, and you can see also the renal infarct. Here it is the same kidney, of course. And when you go later, during the on the angiogram, you see this kidney with multiple spots of vessels, and here no vessel. It is the ischemic process, the renal infarct. In this disease, the majority, we do not know the etiology. Polyarteritis nodosa remains a very difficult disease, and the etiological diagnosis is unknown. But we have seen that 30% of the patients, maybe more, can be infected with hepatitis B virus. It is the consequence of a recent infection. It occurs usually during the first year after the infection. And you will find the viral DNA. The mutation rate is very high, and the replication is also very high. The disease is severe, and these multiple infarcts in all the major viscera have, of course, a big consequence, which is ischemia and the death. And on the epidemiological basis, you can see that now, because we vaccinate patients, because treatments are available against the viruses, because the hospital hygiene is much better than 50 years ago, this disease is progressively disappearing in developed countries. And I've published series of more than 100 patients. And now, when we see 1 or 2 new cases of polyarteritis nodosa, never with hepatitis B virus, we look at them very carefully, but we do not find any infection. And what is also interesting is that some patients who have already been infected with PN, but many years before the polyarteritis nodosa, can develop this PN, but it is only after a mutation of the virus. If the virus remains stable, you will not observe the disease years after the first contamination. It is possible to demonstrate the presence of other viruses, like, for instance, HCV, very rarely. Most cases, it is co-infection. HIV, very, very rare. Parvovirus B19 and Epstein-Barr virus. And sometimes we see some cases like that, and it is really a very severe disease. Here I have shown the frequency of the clinical symptoms in patients with hepatitis B infection. And it is more severe than the other forms. 85% have a mononeuritis multiplex. 75% have a weight loss, not a weight loss of 2 or 3 kilos, 10, 15 kilograms. The fever is present, and high fever. The joint and muscle involvement is present, but there is no arthritis. It's mainly arthralgias and myalgia and skin disease with the purpura. And when you look at the other manifestations, you can see the high frequency of kidney involvement with this vascular nephropathy, the hypertension, but now it is a symptom which is well controlled, GI, which is more frequent than in the other patients, and very rarely central nervous system involvement, and sometimes heart involvement. You know the treatment of polyarteritis nodosa. It is very easy to make. When the virus is not present, you treat with a conventional treatment, steroid, cyclophosphamide, induction remission treatment, then maintenance treatment. Never use biotherapies. Rituximab is not effective, and I don't know if it is positive or negative, but it doesn't work. The second group is when the polyarteritis nodosa is associated with hepatitis B virus. In such case, we avoid steroids or immunosuppressants, and we prefer a more etiological treatment combining plasma exchanges and antiviral treatment. Why? Polyarteritis nodosa is an immune complex disease. Steroids and immunosuppressants, when you prescribe them, stimulate virus replication. It works, but your patient will remain with the virus all life. And when the virus is still present, the risk to have a liver cancer 20 years after is not neglectable. The antiviral drugs, we have a lot now, they lower or suppress virus replication, and plasma exchanges clear immune complexes. Combining these both treatments, we have now good tools to treat the disease and to cure the disease. I will show you the protocol that we have initiated decades ago. It, of course, at that time was vidarabine, which is a very, very old antiviral treatment. Forget it. Nobody prescribes this drug now, but it was the first one. And we treated patients with pulse steroids. And after only 2 weeks steroids, we made a lot, it is a blue arrows, of plasma exchanges, at least 4 each week. And we gave the antiviral treatment. For this one, it was 3 weeks only. And we obtained a recovery in the majority of patients. The first series was 33 patients. We obtained 75 recovery. Of course, 25% of deaths, it's high, but it's not so high when you know how severe is this disease. And when you look at the seroconversion, you have the anti-HBe and anti-HBs, which occur for anti-HBe in half of the patient, which is quite good, much better than in chronic hepatitis B virus disease, for instance. And I will show you an example. It is a young guy, 19 years old, and when he's treated with plasma exchanges, antiviral treatment, you have an increase in transaminase, and immediately after, you have the occurrence of anti-HBe antibody and anti-HBs antibody. And these patients recovered in approximately 2 months. And when you look at the kidney, the angiogram, you can see the microaneurysms before treatment. And after treatment, it is normal, except, of course, this renal infarct, which was initially present. I would like to focus now, close to the conclusion, to 2 new diseases. Now, polyarteritis nodosa is not only an infectious disease, it can be also a genetic disease. And recently, one disease has been described, which is the deficiency in adenosine deaminase 2, and the second one, more recently described, called VEXAS. But we'll focus on the first one. The first one, it is a polyarteritis nodosa, and I have seen some, but very, very special polyarteritis nodosa, because there is a vasculopathy and strokes. And when you remember the slides I've shown previously, the involvement of central nervous system was really very, very low. And now you have this vasculopathy with early stroke. And of course, is it exactly the same disease? In fact, it is not. And what has been identified is a mutation of CECR1 gene, which is responsible for this deficiency in adenosine deaminase 2. AD2 is a growth factor of endothelial cells, cellular differentiations, and leukocyte development. And we understand why it affects the vessels. And in the first paper published in the New England Journal of Medicine, you can see these patients with livedo. You see the vasculitis with the fibrinoid necrosis. And you have all these spots in patients who had strokes. And how to treat this very special disease. Here you have the clinical symptoms of the 9 first patients. Polyarteritis nodosa was present in 2 of 9. The vasculitis was proven in half of the patients. And the other symptom was fever, stroke, hemorrhagic or ischemic, ophthalmoplegia, and livedo racemosa, and also liver and spleen enlargement. What is of interest is that very quickly, the treatment which has been shown to be effective is anti-TNF. And when you look at the number of strokes in 15 study patients with matched timeline, you see that the number of strokes under anti-TNF has nearly disappeared, and it's not neglectable and quite high when patients did not receive anti-TNF treatment. The second genetic disease I would like to show you is a mutation of UBA1 and the presence of a severe adult onset autoinflammatory disease. I will go quickly to the end, and I would like to show you the name of this disease. We call this name, it is in French, but I think that it is easy to understand. VEXAS, because there is vacuoles, there is the activation of the enzyme of the ubiquitin. It is a disease which is present in men, but now we have some women. It is an autoinflammatory disease, and there is a somatic mutation. The patients with VEXAS have symptoms of vasculitis, but it is more chondritis and GCA than PN. But in the initial publication and since the first publication, there is some typical polyarteritis nodosa which have been described. But it is not so clear disease comparable to what has been observed in ADA2 deficiency. The prognosis is not very good. It is more linked to another clinical symptom, which is myelodysplasia, and the other hematologic manifestations. And the patient who recovered sometimes had a bone marrow transplant. It is not exactly the same setting that the ADA2, but I think that it was interesting because when you asked me to cover the topic of medium-sized vasculitis, I said, but it is well known, but in fact, it is not well known. The diseases are rare, Kawasaki adults and children, PN adults and children. The cause remains unknown in most cases, but for the first time, it is with this vasculitis that we have described the responsibility of a virus. After that, you know that cryo, which is a small side vessel artery disease, has been associated with hepatitis C virus. And more recently, we have identified 2 medium-sized vessel vasculitis, which are associated with gene mutations. I thank you very much for your attention.